Hello and welcome, everyone. My name is Renee Garrett, and I'm your speech therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Here are the financial and non financial disclosures. Becky Khayum is the president of Memory and Aphasia Care from 2010 until present time, and the co-founder and care manager at Cognitive Concierge, which started in 2020 and is currently operating. She receives an honorarium from Speech Therapy PD for her participation as a podcast guest. Her non-financial disclosure is that she's a board member of Aphasia Access since 2022 and the co-chair of the National Aphasia Association's Primary Progressive Aphasia Task Force since 2021. My financial disclosures are that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on speech therapy PD, I do receive financial reimbursement. I'm also an adjunct faculty instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Becky Khayum, MS, CCC, SLP, who's a speech language pathologist specializing in person-centered care for people living with different forms of neurodegenerative conditions, including primary progressive aphasia or PPA. She has worked across rehabilitation settings over the past 18 years with a focus on dementia care. Becky is the president and founder of Memory and Aphasia Care, a therapy company that provides participation focused therapy services for people living in the Chicago region, in addition to services that are provided via telehealth around the country. She's also the co founder and a care manager at Cognitive Concierge, a digital wellness company that provides support and resources for families coping with memory loss and aphasia. Becky has collaborated on research initiatives focused on person centered speech language treatment for people living with PPA at the Northwestern Mausoleum Center for Cognitive Neurology and Alzheimer's Disease. She speaks nationally to train healthcare providers and families on how to creatively utilize person centered strategies to address common problems associated with aphasia, memory loss, and behavioral challenges. She is currently a co chair of the PPA task force at the National Aphasia Association. Becky, welcome. It's so nice to finally see you, meet you, and talk to you on this podcast.
Oh, you as well, Renee. Thank you so much for having me, and always so excited to talk to everyone who's here now or watching this later about primary progressive aphasia.
Yeah, and it's such, I've done a couple of podcasts on this topic, and one of the one that sticks out so clearly for me and was probably one of the most pivotal podcast episodes was talking to a caregiver of a patient who is no longer with us, but she was the primary caregiver for her husband who had PPA, and it was just a really, really powerful episode. And I think that's one of the driving forces, but for me to continue to highlight this disorder and bring things to the forefront about how we as SLPs can, be more mindful and have more accessible care for these patients because it is still kind of considered a rare diagnosis, right?
It is. And I think certainly we, in the general research community assume that it's probably underdiagnosed or misdiagnosed, or by the time people go, get to a neurologist, it's progressed. And so they're not sure what exactly they have in terms of form of dementia. So it really is a huge problem. But we have found that more and more places, especially in major cities, more neurologists and even primary care physicians seem to be, we see more accurate diagnoses coming in. But at the same time, when I'm facilitating the PPA chats at the National Aphasia Association, story after story, still of people going 2, 3, 4 years before getting a diagnosis after being told they have anxiety or they're going through menopause, since it often is an early onset dementia. So yes, so absolutely, that's such a great question.
So, can you describe for us the diagnosis of PPA or PPAOS and kind of those key facts that are really kind of crucial? We have
Yeah.
these markers we look for, but obviously we're not the ones who make the diagnosis, it's the neurologist or the
Mhm.
neuropsychologist, but having that description I think helps us
Yeah.
even if we get this, because a lot of times, especially in outpatient, we get this sort of nondescript diagnosis of a cognitive disorder or a language disorder, and we don't really know where to go. But we need to be mindful of what the diagnosis and the key facts are that can help us refer back to that neurologist to help make this diagnosis for the family and the
That's such a
patient.
good point. Yeah, whether you're the individual, client with aphasia comes to you already diagnosed, or you're thinking, okay, is this an accurate diagnosis, and looking for the hallmark signs to refer back for an accurate diagnosis. Yeah, so I think, primary progressive aphasia was first described by Dr. Marcel Mechoulam in 1982. So for being a rare dementia, it is quite a while ago. And before that time, everyone just assumed that Alzheimer's dementia and memory loss was synonymous with dementia. And so this is when, researchers started saying, no, wait a minute, we're seeing people who have no memory loss, but language loss. And that's
Mhm.
getting worse over time. There must be something else, some other form of dementia going on here. And certainly since then, lots and lots of research getting us to where we are today. I think I always like to start when I'm thinking about PPA, certainly recognizing that it is, we're seeing impairments in language, whether it's expressive, receptive. We're seeing difficulties in reading and writing, and usually slow onset. And then we're seeing those symptoms progressing over time. But the important considerations are that these are in isolation initially of any other cognitive domains being impacted. So if someone came and they truly had memory loss or they had a lot of changes in personality and behavior, that wouldn't be considered primary progressive aphasia. It's really those hallmark deficits, because that's where that very specific part of that language region, frontal temporal region, where the disease initially starts in the brain that's causing that person's symptoms. And so certainly there are different described variants of PPA, and I can certainly go into those, but each variant really describes kind of a cluster or hallmark symptoms that would be associated with that specific variant. So would it help if I go a little bit into that and then say, as far as speech language pathologists and SLP, how much should we focus on those variants? Would that be helpful?
Absolutely. Yes. Thank you.
For sure. So let me start with semantic PPA. And I think one of the most striking things is just how fluent these individuals are. And I would say, just in my experience, it really takes a long time for them sometimes to get diagnosed, because the doctor will look at them and say, well, you're talking just fine. I don't understand, what's wrong with you. You don't have aphasia. And so they sound very fluent, and it's really that losing the semantics of language. So that
Mhm.
single word recognition, whether it's auditory or whether that's recognizing a single word, that is really the hallmark characteristic of what we would see with someone with semantic PPA. So you might say, hold up a picture of an apple and say, what is this? And it's like they just might even say, well, or you say the word apple and they're saying, well, what is an apple? So just losing the meaning of that word altogether. So, and then eventually, as symptoms progress, having more difficulty recognizing images and pictures, faces as well, until comprehension becomes extremely impaired, certainly retrieving the words, the semantics to just have meaning within the sentences is very difficult. So maybe we still have some grammatical structure, but it's completely lacking content words. So that would, pretty much describe a person living with semantic PPA. But I always like to think about strengths as well. So certainly just that, okay, grammar is good, that kind of back and forth conversation as far as being able, especially initially, to communicate well, just really needing some support, right? With comprehending
Right.
more complex speech
Mhm.
or reading more complex, novels or whatnot. But in memory, certainly short-term memory, long-term memory, initially very intact. And certainly later we can talk about as things really progress to non-language cognitive regions. Renee, we could maybe talk more about that later as we speak about progression. So let me move on to agrammatic or the non-fluent variant of PPA. And so the kind of the hallmark characteristics would be, of course, grammatical errors, difficulty forming correct grammatical construction in sentences, maybe the abnormal word order, for example, having a lot shorter sentences, certainly having some word finding difficulties, but sometimes, pulling out single words, content words actually is a relative strength. It's just more putting those words and constructing that full sentence is difficult. Some people living with a non-fluent agrammatic variant of PPA do have apraxia of speech, not all. And so that can also be another struggle of these folks. And since we're talking about this subtype, a very similar diagnosis is the primary progressive apraxia of speech, where we don't have aphasia initially. We just have apraxia that's getting worse over time, again, just because where that neurodegenerative disease starts in the brain. So strengths for these folks would be a single word comprehension is good, knowing the meaning of words is very good, using those content words in conversation. So moving on for the last variant, which is logopenic PPA. So logopenia, just that difficulty finding words. You'll see a lot of frequent hesitations in speech, kind of talking a lot around that missing word. Initially, as things progress, of course, it gets harder to talk around the word because we can't find the words to use to talk around the word. So certainly getting more and more difficult. Comprehension of longer sentences over time, kind of that auditory working memory gets more difficult. A lot of times I'll see, they always have difficulty with repetition, but that's not always true. Some people may, but some not. And certainly strengths would be knowing the meanings of words, initially really talking around those words, the single word comprehension as well. And so those, again, I like to think about strengths versus challenges for all three of these variants. With that said, I always say it's really important for us as SLPs to be very familiar with the different variants, because I do think that is important when we're seeing someone. In our mind, it's like, okay, we would expect for these to be kind of those hallmark symptoms that we're seeing. However, everyone's so different, and they're different in the way the symptoms impact them because this is a disease that's spreading over time. Just one evaluation is one evaluation. That's a glimpse in time where things are always changing. And so when I see someone today that might be and see their symptoms today, it might be different in a couple of months. And we start seeing people with certainly mixed symptoms from multiple variants. And so that, I think, when people become very focused upon what variant do I have, I try to say, it's okay if you're a human being. In research, it's really helpful to have different categories. And so I always, make sure that I let SLPs know, don't focus your therapy based upon the variant. So it's this variant,
Mhm.
therefore, these are the interventions we're going to use that are for that variant. We really want to stay away from that. So sorry for that really long explanation, but a lot of information packed into those variants for sure.
No, that's a great, great explanation. And I think for me, like, when I was working in an outpatient, my last PPA patient was definitely someone who had the logopedic variation, but also, like you mentioned, as it, in lack of words sometimes, as it morphed, because really that's what it
Uh-huh.
is, right? It's progressive, so it's changing,
Yeah,
and it's different from day to day. It's from week to week, and we know that there's a
yeah.
lot, even with our patients with aphasia based on having had a stroke, the
Yeah.
life, the life things, right, impact stress, impacts mental health, impacts. This patient had a son who was getting ready to get married, and he was very concerned about not being able to speak because he was the best man, and so there were a lot of concerns about that. And but his word finding was definitely an issue, but also, like you mentioned, one of the things that was a challenge for him was when I would ask a question, or his wife, who was just a great caretaker in the participation of therapy and in life in
Mhm.
general,
Oh, good.
she would ask him questions trying to help prompt him, and he would start and then just completely lose
Yeah.
his training where he was at. And I think that's a great space to say, is this a form of dementia? Because a lot of people get really
Mm.
confused by that
Oh,
when
yeah.
it's a language disorder, and then they don't want to relate it to cognition or a dementia because that sounds so much more negative, I guess, in some people's minds. But we know that a lot of people with dementia have variations of aphasia that are not typical from what we
Mhm.
learn in school as
Yeah.
aphasia as a language disorder related to a stroke or TBI. And we sort of miss this train of, aphasia can be a part of these other progressive neurological diseases. So based on your expertise, would you say that this is a variant of a dementia or a subtype dementia?
Yeah, that's where you're absolutely right. The nomenclature is so confusing, and it's actually used in my very inconsistently, even throughout the research world,
Yeah.
and certainly any neurologists across the country may be using different lingo. So for me, it's like, okay, I can barely keep track of this and the changes. How in the world are our families supposed to understand their diagnosis? And so I can just, this is how kind of the framework that I use in my mind based upon the training that I've had. But certainly just know I'll kind of explain how I think about the nomenclature. But this could vary a little bit from what you hear from reading other research studies and whatnot, because it always is changing. But yes, I always start off just kind of, let's start up here and just with the word dementia. What does that word mean? Because as we talked about before, since before 1982 or when they started describing other forms of dementia, Alzheimer's was assumed to be synonymous with dementia. But we know that's not true. So dementia really is just a very general term. It just means we're seeing a progressive loss of cognitive function. So it could be memory, it could be language, it could be executive function or personality and behavioral changes. And it's really when those symptoms are severe enough to start impacting daily life, that's when we would say, okay, that's dementia. However, some forms of dementia are reversible and some are not. So that's where it's really important that the individual goes to hopefully a memory clinic or somewhere where they can really rule out, okay, is this due to alcoholism? Is this due to some metabolic issue or maybe a UTI? And so we rule all of those things out. But the type of dementia that we all think of is, of course, a dementia syndrome that's caused by neurodegenerative disease that gets
Hmm.
worse and worse over time. So there's dementia. That's what that means. But let's break it down a little further. So, this dementia that's caused by neurodegenerative disease, there are many, many different forms of dementia, but just kind of grouping them into some of the major categories as described by the researchers. So, Alzheimer's dementia is about 50 to 75% of cases that again are documented, and vascular dementia is kind of 20 to 30%, Lewy body 10 to 25%, and then we get down to frontal temporal dementias. And They, again, are estimating those to be 10 to 15% of all dementias. But as we said before, probably a little low because these folks aren't diagnosed correctly or misdiagnosed. So we've got frontal temporal dementia. What does that mean? I know Bruce Willis came out and just his family and just being willing to share this diagnosis with us and becoming such advocates for
Yeah.
people living with FTD. I always say we are beyond grateful to them for sharing and becoming such advocates. But okay, what is frontal temporal dementia? And I always say this again, like the word dementia, this is an umbrella term. So frontal temporal dementia means we have neurodegeneration that begins in the frontal temporal lobes of the brain. And there are different types of frontal temporal dementias. And in my mind, I group them by symptoms. So the first kind of category would be types of frontal temporal dementias that the primary symptoms are speech or language. So therefore, of course, that would be PPA and PPAOS. Another form of frontal temporal dementia is where the first symptoms we're seeing are personality and behavioral changes. And that's where
Mhm.
we get our behavioral variant, FTD. And then we have our motor forms of FTD, where we have both motor impairments, movement disorders, but on top of that, because we have atrophy in the frontal temporal lobes, we also have language, personality, behavioral changes as well. So those three diagnoses would be progressive supranuclear palsy,
Mhm.
PSP, cortical basal syndrome, CBS or CBD degeneration, and ALS FTD. And so that collectively would be all of the different forms of frontal temporal dementia. So that's where, when we're thinking about dementia in general, yes, PPA is a type of dementia because we have symptoms that are getting worse over time. They're caused by a neurodegenerative disease in the brain. It is ultimately fatal. While we have statistics of people after onset of symptoms documented from 2 to 20 years, I'd say the average just documented is probably more 7 to 10. But certainly those that do have heavy motor involvement in the beginning, knowing it's closer to perhaps the swallowing center, breathing centers, that would be, and kind of that rate of progression of those motor difficulties, sometimes you could see that progress a little more quickly. And so SLPs want to make sure they're really cognizant of that. But hopefully that helps. And I think the only other thing that's really important for families to know is, okay, so we now have dementia, right? And that, of course, is heartbreaking,
Yeah.
beyond heartbreaking, devastating. When they got this diagnosis, I've had people say that their neurologist did not tell them that it's dementia. They just
Yeah.
thought, okay, my speech is going to get worse until it's gone. And they don't realize they're like, well, at least I don't have Alzheimer's. When And this is just my opinion, I actually think that it can be almost worse than Alzheimer's
Yeah.
because the person living with PPA, their memory initially is intact and they're so insightful into their diagnosis and really know, just that's what makes us human, is be able to speak and read and write, and just slowly having that taken away, just watching that slip away every day. To me, it's just the most heartbreaking diagnosis I can think of. But the only other, and I'm only explaining all this because families, we may be the first person who can explain this to them. What's causing this? Like, I don't understand what causes it. And that's where I try to keep it simple, but I just say there are different types of proteins in the brain that it's kind of abnormally starting to aggregate, like clump together, and then they start accumulating in the brain. And then the neurons they don't work properly, and eventually they die. And then it spreads over time. And there are, unfortunately, many different types of these proteins. And so I'll explain, some types of sometimes PPA is caused by amyloid plaques and tangles, the Alzheimer's disease, amyloid plaques and tangles. Sometimes PPA can be caused by tauopathies, which is
Yeah.
another kind of family. There's like TDP43, which is a whole nother type of protein that can cause PPA. So I try to explain that, especially with those who are diagnosed with PPA and then they have like a spinal tap or an amyloid PET scan, and they're told, well, you have Alzheimer's disease too. And they're like, wait, what? And they think now they have PPA and Alzheimer's dementia when it's really just that the disease, the amyloid plaques and tangles, that happen to start in the language center of the brain
Yeah.
instead of in the hippocampus. And so I draw pictures. Although I always ask, tell me from a counseling standpoint, tell me what you know about PPA. And I kind of listen and then to understand where they're at. And then I say, well, tell me, how much would you like to know? And I have some people say, I don't want to know all the details. And I have some where the care partner will say, I want to know everything. I want to plan for the future. And the person living with PPA will say, I don't want to know. So
Yeah.
it's, kind of all of this information is really important for people to know, but I'm always kind of thinking about how ready they are for that information. So that again was a very long-winded answer, but I think that's so important for us to all know, so we can really educate these families about how to plan for the future and what to expect with this awful form of dementia.
Well, and I think there's two really great, I mean, all of that was a great point, but two really great points is thinking about what our caregivers need for us to support and what our patients need for us to support. Because a lot of people, a lot of our SLP community, SLPA community, they shy away from this counseling aspect. But, I came up in the realm of TB working in inpatient rehab. And so
Yeah.
I was doing education as part of our rehab process early on in my career, and I just felt like the counseling piece. I took a lot of CEU courses on counseling for SLPs to be able to say I'm not a psychologist, and that's not what when we say counseling, that's not what we're talking about. We're
Right.
talking about providing education, providing resources, providing avenues for advocacy, but then also knowing that we can request a referral from the PCP for
Mm.
counseling that's maybe more neuropsych or just counseling, right? Because a lot of our patients and
Oh yeah.
especially the caregivers need that. They weren't expecting this. They're not asking for it. PPA is not a result usually of a one-time injury like a TBI or an insult like in the in a CVA or a stroke. This wasn't an anticipated event that happens. And so our role is to provide this access to other avenues of care, but also to say, like specifically you said, how much do you want to know? Or respecting if they don't really want to realize how devastating or how bad this may look
Yeah. Yeah.
long term. And I
Right.
think that's such a valid point because a lot of times we're the fix it people. We wanna fix it for
Exactly.
everyone.
We want to fix everyone. Yep. Yep.
Yeah, but sometimes our role is not to fix it. Our role is to be respectful of the client, the patient, where they're at, and what their needs truly are, the role of what we can do. How do we move forward into assessment? Because I think that's a lot of a big place where people get stuck, but
Yeah.
particularly students who haven't seen this or learned about it in their aphasia course or their neuro communication disorders course. How do we move into knowing standardized tests? Are they appropriate? What do we do? Kind of how we assess this, because a lot of us who have done it for a while, we focus more on the informal and the sort of that priority vocab, getting that in place, talking to the
Yeah.
caregivers or the family members about what the importance of their communication needs are. But unfortunately, we're often dictated by insurance standards and things
Mhm.
like that. So what standardized tests do we use? What do we do?
Yeah, that's such a great question. And I think for me, I'll say a couple of things, but it's really hard because I know we're trained often in more of diagnostic testing, right? So we're going to go in and we're going to figure out what people's impairments are. And it's these very impairment focused standardized tests. If
Hmm.
we're working with the neurologist to help diagnose the individual with PPA, great. Those tests are perfect because we need to look at that profile of strength and weaknesses in order to diagnose that person. But if we're really thinking about, okay, I want to create goals, person centered functional goals, and a plan of care that's actually we're going to be able to demonstrate progress for research, just those typical impairment based diagnostic tests, if anything, you get a score and you discharge them from therapy and they have the same score. In this population, that's actually good because we would
Yeah.
expect it to go down. So that I talk to a lot of people who say, well, my SLP, they discharged me. They said I can't come anymore because there's nothing that they can do for me. And then I'm not, I'm not meeting my goals, or, they can't demonstrate progress. And so I think I kind of take a step back and I say, okay, let's start off with the person. And that's where before I talk about the assessments, I always use that framework of the life participation approach for aphasia and the framework of the AFROM
Yeah.
framework by Kagan and colleagues, just living with aphasia, that framework for outcome measurement. This has been a really useful tool for me before I even think about the standardized tests that I'm going to use. When I'm doing a motivational interview with someone, I'm starting off there. I can't tell you how often, I own a small therapy company, and my office manager will say when people call to schedule their evaluation, one of the first questions they ask is, are we going to be tested? Because if we're going to be tested, we're not coming. And because they've already been through so much testing,
Yeah.
it's
Yeah,
so
because like you said, it's a lot of times it's 2 to 4 years of all this testing before they finally get a diagnosis, and it's
right.
I can only imagine how incredibly frustrating and just exhausting that is.
Right, right. They're coming to us thinking, okay, here's someone who can help me. And then it's like we're whipping out the
Finally.
standardized test again, right? So that's where for me, it's like, okay, what are the different domains of the life participation approach in AFROM? And so, okay, we have that language impairment. That's one of our domains. If you look at this diagram, it's a beautiful diagram. I kind of keep it in my mind whenever I'm doing an assessment. But then we have three other domains we're really thinking about. And one is, it's actually, how is their PPA, their aphasia, impacting all of these other domains, the other important things in their life. So, how is their aphasia and their impairment impacting their ability to participate in meaningful activities that they love? How is it impacting their ability to communicate in different communication environments and with people that they want to communicate with, their social network? How is it impacting, most importantly, their role in life, their emotions, their sense of identity? If they feel like that's being taken away from them, that's just the ultimate sense of our human dignity, and which is what this disease can do to people. So for me, I'm thinking, okay, let's do more of a motivational interview. I'm going to get to know them. I'm going to ask some questions based upon, okay, well, let's talk a little bit about, tell me a little bit about what environments do you like to, where do you need to communicate? It's obviously it's at home, but do you also go to book club? Do you go to the doctor a lot? Where do you need to communicate? And who do you want to communicate with? It's sometimes, it's high school children because they're in their 50s when they get diagnosed with PPA. So it's very important for them to speak with their children. Sometimes it is emotionally based. Like I am a doctor, I am a lawyer, I am a teacher, and I can't do that anymore. And I've lost my purpose and role in life. And so, that is important information from a goal setting perspective. And then I always have a little chart of, okay, let's go through, what are your interests? What are your hobbies? What are things that you've always done? And once I get that full picture of the person, and then say, okay, now let's talk about what's hard for you. Where is it hard for you to speak? Who is it hard to speak to? We go into reading and writing activities. Once we have that conversation, this is where I like to use Michelle Bourgeois. She has a wonderful model called Flip the Rehab model.
Yeah.
And it's basically we're flipping everything around. So rather than we're testing someone, we're looking at what their impairment is, and then we're forming goals based off of that. Instead, I'm saying, okay, so this person is having trouble doing their daily schedule, and it's difficult for them now to communicate with their spouse. They're getting confused about the schedule during conversations with their spouse. They're both upset about this. That's the complaint, right? Okay, well, then I explain to them, I'm doing a small assessment because I want to find out, is it because you're having trouble comprehending? Is it because you're having trouble writing in your schedule? Is it that you're having trouble reading what you've written in the schedule? So it's basically what are the person's goals and how are their impairments, their ability to participate in that activity or with those certain people or in that environment. So with that all said, that's kind of my approach is let's do motivational interview first, and we're thinking about standardized tests last. And it's also a misconception that a standardized test score has to be documented in order to receive Medicare reimbursement. Actually, what auditors are looking at is an important part is the narrative. So everyone who in your EHR, there should be a narrative. And in that narrative, that's the crucial part where you put the details of that motivational interview and you put these are the problems that the person described. This is how it's limiting them from participating in
Yep.
daily life. And you list their goal. These are the things that they're concerned about. And then it's all about the goal formation. So we have to work with the person to write goals that are meaningful and important to them. And you all know the SMART goals and whatnot. I know we don't need to talk about that. But then once we create those goals, it's making sure in this population that it's realistic in terms of we might not get them to 90% accuracy, and that's okay. Maybe we need a moderate level of care partner cues. That's
Hmm.
okay, right? They don't have to use these things independently, and they're going to be able to meet those goals with the care partner training and whatnot worked in. And then if they're very functional goals, like they're going to be able to order coffee at Starbucks using a script and in rehearsal or a visual aid or perhaps their phone where it's written on their phone or a speech generating device. Well, now we've written a very personalized goal that we can meet hopefully and show progress towards. So with that said, you do not have to have a standardized test score. But if you do really want to document a score, I always go to functional communication tests or I'll give a subtest. So I might give the CATL, I might give a subtest from the assessment for living with aphasia, which is based on AFROM. It's a nice assessment. There's also the communication confidence rating scale for aphasia, which is a very quick scale where it's just looking at their communication confidence in different functional situations. Certainly there's the ASHA facts. And so if I am going to use a standardized score, I'm making sure that I'm putting that at the end rather than at the beginning and that it's very functionally based. So in my mind, I don't know about you, Renee, but that's kind of how I approach assessment and really thinking about how are we going to get also reimbursement for this as well. I know that's very important.
Yeah, no, I think that like you said, I don't necessarily call it the motivational assessment, but I might rename it. I feel like having a, just having this patient centered, you know, and I guess I changed the way that I assess patients quite a few years ago when it came to aphasia and TBI, in that when I have to give a standardized assessment, I'll say I don't want you to think of this as a test. I want you to think of
Mhm.
this as a measure of me being able to understand what you're good at and what's difficult for you, but also how I can brainstorm what helps you. What
Yeah.
helps you
Yeah.
be more functional? And then a lot of times when you approach it in more of an it's a standardized test, so you have to follow the norms and
Right.
the
Right.
requirements for assessing. But when you approach it in the way that you're saying, I don't want you to feel like we're back in high school or middle school and we're
Yeah.
having this test. It's going to freak you out because we all have test taking anxiety anyway. I
Yeah.
don't want you to approach it that way. I want you to approach it in that, show me what you're good at. Show me
Mhm.
also what you're not so great at. And then
That's
we can
right.
figure out
Yeah.
together with the next questions that this next set of questions that come after that, how I can help you or how we can work together to figure out what helps you, because a lot of times that is well, really 99% of the time is far more meaningful and
Yeah.
far more helpful for the patient. I
Yeah.
think it's a
Yeah.
great point to do these rating scales too
Mhm.
that are more of a patient reported outcome measure, the PROMs
Right.
that are
Right.
so often undervalued and I think underlooked by a lot of people who are managed by people who maybe aren't speech
Yeah.
language pathologists,
Yep.
right?
Yep. For sure.
Because we get that pushback, but at the same time, it gives us such valuable information that, again, you brought up some really great points about maybe they're not going to be able to have 100% accuracy or 90% accuracy, but one of the things that I've seen pushback on from colleagues is, you mentioned speech generating devices and kind of like in a roundabout way.
Yeah.
But a lot of times people will say, why would you get someone with a PPA, a speech generating device? They're not going to be able to use it because maybe they do have some motor apraxia or some motor deficits. But why would you look at that? Because they're not going to be able to use it. I've heard that so many times and it just honestly just irritates me because I think if you're training that, again, we're 2 to 4
Mm.
years into the diagnosis process, but if you're still getting that early on with someone who's got a 12-ish, 15 maybe year life expectancy post-diagnosis,
Mhm.
we know at that point, 2 to 4 years in, they probably have already had it for a while, right?
Mhm.
We're talking
Mhm.
numbers of years at
Yeah.
that point.
Right.
So why wouldn't we be looking at speech generating devices for these patients?
Right. And I think it's really gray. It's not really black and white, when I'm thinking about this. It's so many variables that I think about when I'm working with someone. And first of all, it's not like, oh, you have PPA. Okay, we got to do an evaluation for a speech generating device. You're getting to know them. And I will say this question about speech generating devices comes up. I run 2 monthly PPA chats at the NAA, and almost every chat this comes up. And some people will show their devices, others will indicate, well, we have them, but we never use them.
Yeah.
So I think it's a lot of variables to consider. And certainly, yes, it is progressive. And by the time they do need to use it, you need to think about this is where I do think about the variance a little differently, because when you have someone with a fluent, non-fluent agrammatic PPA, especially with and PPA-OS with a lot of apraxia, we're losing speech very quickly, but our ability to write and, type into a device, or really be able to sequence, to go to the different screens and have that capacity to use the device when speech and language is severely impacted. That I've seen people with that subtype use a speech generating device much more effectively. With that said,
Mhm.
there's no research that I've seen that looks at longevity, and longitudinal use of speech generating devices in PPA. Needs to be researched, but
Yeah.
this is just in my experience of working, with over 100 probably families living with PPA. And for so that's one thing to consider is, okay, with semantic PPA, our comprehension by the time our speech it's fluent, but there's no meaning behind in a lot of the sentences. We're not able to understand what they're talking about. But if they're not able to comprehend, or they're not able to recognize words or faces or pictures at this point, is that really going to be a successful device for them at the point when they really need it, right? For
Mhm.
getting the message out. Now, I'll talk in a moment about how maybe for comprehension purposes, how could we use technology? For someone with logopenic PPA, it could be mixed, right? Because we know sequencing and visuospatial skills certainly can be impacted, especially those visuospatial skills maybe a little earlier on. And so we have to carefully consider that. But holistically, when I'm thinking about this, is do we have a care partner who is
Mhm.
there, who's willing to be trained and is good with tech and knows from the start that they will likely be the driver of this device as things progress? Because I've seen a lot of unrealistic expectations set where, oh, okay, this is great. They're going to have this device and they're just going to use that to talk and everything's going to be great. And there's not this sense of, well, no, you're probably going to be the one initiating use of the device or helping them navigate to the different pages. Or maybe you're really using it for comprehension purposes, not even for output purposes, unless you're really helping them to push the buttons and get the message out. Number two, it absolutely requires, like you said, we got to start early and we need to make sure it is ongoing programming to meet their needs, ongoing training. There has to be integration into conversations. Like we have to really be practicing in therapy sessions using this device over and over again for conversations, or it's not going to get used at home. So I always like that's another critical point. And then it's just motivation. If the person can't, if they don't want to use it and they don't like technology, why why would they use that to help
Yeah.
them communicate? And if they can't use a phone very well or a TV remote, how are they going to use this unless they're care partners? So is there. So I always say, um, it may very well be helpful for people as one tool in a
Mhm.
large box of tools where, okay, we have this device. We know that we're going to be FaceTiming with family members. We have a script on the device. It's all set. And we can use questions that are programmed and whatnot to go back and forth in a conversation. We have the setup, or we train the care partner here, pull up this page, and perhaps for semantic PPA, rather than just still pictures, maybe we have videos in there because we know visual process of verbs and actions is a little more preserved in that population. So maybe we have recorded videos that of them telling stories. So anyways, all of that, which to say, I think it's very different for each person, as know as well, and it's something that should be considered not at one point in time, but over time, and then really thinking about, is this going to be something that they will actually use? And if not, well, may not be the best thing to put our focus on. Whereas all of that training could be going into making low tech aids or using the iPad,
Mhm.
I'm sorry, smart tablet to do other things. So sorry, that was a really long answer, but I get that question so often. So that I don't know. What are your thoughts about that? It's a hard topic.
I agree. I have a colleague right now whose dad has PPA, and it's been
Mhm.
a I was a colleague before, but this is someone that I haven't worked with for a long time, and she has a pediatric background, whereas I have an adult, and so her advocacy efforts for her dad were to reach out to people that she knew who staunchly told her no for an SGD early on. Whereas now that I'm seeing where he's at now, I think it might have been helpful for him and
Mhm.
the family to be trained early. But now it's, I hate to say too far gone, but he's
Yeah.
now mostly nonverbal and his
Yeah.
comprehension has declined so much that I don't think at this point it would be
Yeah.
helpful, but I
Right.
don't, it's so hard to predict. Like you said, the variants are, they don't follow a typical progression. Not that
Right.
any neurodegenerative disease does, right?
Well, right. But yeah, yeah, you're absolutely right. Yeah. It's so
So
hard.
it's very difficult to say, the chick what came first, the chicken or the egg. But for him,
Right.
maybe if they had this, and that's the thing, like the technology has changed so much for
Mhm.
SGDs in the last. even 5 years, but 10 years. I mean, when I first started practicing, it was like a one or two, three choices maybe for
Yeah.
patients with aphasia.
Yeah,
And
right.
now it's like I'm seeing patients with intellectual disabilities, with autism, who are adults who
Yeah.
live in group homes and go to day support programs, and they're utilizing these immediate choice that aren't just like a talking brick, or they have like a device that talks, but they know how to navigate it because it's more simplistic and related to their basic needs and their environmental cues, and they're able to,
Yeah.
I want coffee, I want to shower, I want to be alone, whatever it
Yeah.
is, and
Yeah.
10 years ago, it wasn't that. You're navigating, like you said, through these hierarchical menus, which again, it's not a bad thing if you have the syntax and the semantic knowledge, but if you're trying to work with someone who's lost that skill set,
Yeah.
it's a little bit more of a challenge, and where do you start?
Right. Right. I completely agree with you. It's so tough. Yeah.
Yeah, and I think we were taught, like, for me, I had an AAC course in school, thank goodness,
Mhm.
but we were taught to, if you're gonna use AAC in a high-tech device, you wanna shoot for the stars, you wanna look for what they're gonna need 5 years from now,
Right.
not what you could train them on the more complex device, whereas now it's more
Right.
like, yeah, you want it to be long term and longevity for the client or patient, but you want it to be also realistic to what their needs are now. And if it's a progressive neurological disease 5 years from now, are they still going to be able to access this device and have it to be meaningful for their communication?
Yeah, exactly. It's really weighing and balancing, and then just incorporating the person's and the family's input and kind of making that decision as a team. But at least they do, doing a trial and whatnot, and of the device, I always encourage families to try that if they're at all interested, just to even get a feel for it. So, but yeah, if they're already pretty impaired and further along in the progression, it why not focus on other things that are probably going to be immediately impactful? Yeah, and daily communication.
Yeah, well, and that's a great segue into my next question, which is more about evidence-based interventions. Are we looking at impairment or restitutive interventions, or more compensatory, and then how? And we've touched on this a little bit, involving the caregivers, because I
Hmm.
think also sometimes people get hung up on caregivers being spouse or
Hmm.
uh,
Yeah.
adult child of a parent with this disorder, but sometimes the caregiver isn't that person.
Yeah.
So,
Yeah.
kind of where do we focus our treatment, and how do we move forward after we've done the assessment and trying to figure out what's important to the patient?
Right. Yeah. And they're certainly just talking about all of the evidence based interventions that are out there that are currently being researched. That could be a whole another hour on its own, as you well know. I think the most important thing to think about is, yes, we have lots of these restorative, whether it's semantic feature analysis or the lexical retrieval cascade or the VNest or script training. We have different evidence based types of exercises that we know with this population. We don't know if practice words that are untrained, if there is generalization. It would be great if there is, but I always say if we're going to work on a script or work on, our lexical retrieval exercises, it's really important to make sure that we're working with that person. You already mentioned it. Their family members all along in those sessions together to come up with words and scripts that are meaningful to them that loop right back into those goals, into those life participation activities. And then at the same time, we're thinking about compensatory strategies, which certainly includes AAC, whether it's high tech or low tech. I mean, that could be as simple as training someone to create different photo albums on their phone with captions on the pictures to help them communicate. It could be having a script in their phone or on a note card that they're going to use to communicate their favorite flowers in their garden when they're talking, to their neighbor. And so I think, to me, it's important. The most important thing is we got to get away from the workbooks. We got to get away from the worksheets.
Yep.
Those, that's probably, there's not evidence behind those. And so we really want to, and we're not doing brain games and things in the sessions. We really, as you said, care partner, whether it's, and especially with telehealth, it's great because I've had both children and spouses. I've had
Yes.
friends there. It's great. Or invite them into the therapy sessions. Unless an individual is very uncomfortable with people being there during the sessions, which if you're not testing them or making them do worksheets, if you're making them do that, well, yeah, they don't want people there because they're embarrassed. If you're really working as a team, talking about, okay, how are we going to get you talking better at gardening club, or book club? It's then a team approach. So to me, it's really important for each person to think, okay, do they want to do some exercises that focus on like personally relevant vocab words or scripts? And then at the same time, we're training on, okay, here's a detour. If you can't get that word on your exercises, we need a detour to get that message across. And so it's a combination of those different strategies unique to each person. And then we're changing though that kind of balance however we're integrating those into our goals. It's probably going to change as the disease progresses and care partner support's just going to continue to go up more and more. But yeah, they should be involved from the beginning.
Mm-hmm.
I
Agreed.
agree. It's so important. But yeah, does that make sense? Like, would you agree kind of with that, kind of the blend of the different
Oh, absolutely. And I
strategies?
think
Yeah.
a lot of times I feel like I was taught that as a component of aphasia, circumlocution was a bad thing, but circumlocution is a great thing because
Right.
if you can describe what you're trying to say and the person who's your communication partner gets it, at the end of the day, that's all that matters. They get
Yeah,
your message, they're receiving that message, they're able to comprehend what it is you're trying to say. So even if you can't say the basil plant, you could say the Italian spice that tastes like licorice, or just I'm
yeah.
looking at my basil plant and
I
random.
love it. I like, well, yes, that's important in your daily life, that word.
Yeah, I mean, I think that's so important for people to realize that a lot of times our messages are not fluent. As professionals, our messages are often impacted by our fatigue level, our stress level, things that are extracurricular activities or things that are going on with your family impact your ability to communicate for people who don't have a communication disorder. So then when you compound that with a communication disorder and you're able to say, okay, well, yesterday I was really struggling because I was so tired. How are you feeling today? And what thing helped you communicate with your spouse or your child who lives in another state that, or another country even, that you have to communicate via your phone, whether it's email or a phone call or a FaceTime. Yeah, I think it's really important to know that our communication isn't always perfect, but how can we make it effective,
That's such a good,
right?
yeah, such good counseling right there. Yeah, yeah, for families. I love it. Yeah, it's getting the message across is the goal. I always say we
Yes.
have a lot of different ways we're going to get there, but it's a team approach always. But yeah, for sure. And just whether it's stroke-induced aphasia or people living with PPA, that same philosophy doesn't change. Yeah, absolutely.
Yeah, and I think too that, we get, again, as SLPs, a lot of us get hung up on the documentation process and how that looks. And you made a really good point about documenting what their needs are from a day-to-day function level. And you can write your goals that way and you can document your goals that way. But and I full disclosure, I teach a technical writing course for undergrads moving into grad school. And I tell them all the time, if I were to come behind you, say you're a working professional and I have to cover for you because I'm PRN and you're sick. You
Yeah.
went out sick and I have to come behind you and look at your note and know what to do with this patient. I need you to paint a picture of what happened. If I
Yeah.
read
Yeah.
your documentation, would I be able to jump off that and say, oh, this is what you worked on last week or yesterday or whatever? Because we know it's not, therapy isn't always consistent. People get sick, people have transportation
Oh,
issues, or whatever the case may be. If I can read your note and say, oh wow, okay, I see you were working on categorization, but also with their priority vocab list, and also you're working on conversational communication partner training, and
yeah.
I can jump on that immediately. So
Yeah.
if you're documenting that way, simplistically, right? You don't have to
Mhm.
make it a 5 to 6 paragraph situation. You can just
Right,
say,
right. Yeah,
exactly those things, like, you're working on XYZ. Now I can come in and jump on that and document for you too, because 'cause you're coming back in after you're sick, maybe you don't feel
and
so great.
I need to know what you've been working on. Oh, exactly. Yes, and
Yeah.
those functional goals, if they see they're gonna be reading this magazine, using this strategy or whatnot, it is also much easier, I feel like, to fill in then. It's like, "Oh, I actually know this person, like, in their interests," and it's not just they'll name 5 animals in a minute or whatnot.
I hate that so much.
It's like,
Or when you look at, well, yeah, we could talk about this for a whole other
I
hour.
know.
So we do have a question. So it
Mhm.
says, you mentioned the name of an approach for an intervention. Please repeat the name. And I know that I typed in the life participation approach and AFROM. So Kathy, who wrote the question, I'm not sure at what point, or
Let's see,
Becky, maybe.
approach or intervention. Yeah, I'm trying to think of when this was. It would have been, yeah, maybe A from.
Yeah, that's
I'm
what I
trying
was
to
thinking
think. You
too.
look up Kagan and colleagues on online. There's some really nice articles on that.
I did type in the aphasiaaccess.org too, because they have
Yeah.
the videos
Oh,
with,
great. Yes. Excellent
yeah,
point. Yeah.
with Leo Attorney and, oh gosh, some other, this is where I start failing in my life here. Nina
Uh-huh.
Mackey.
Mhm.
There's some really great videos on there, and they're not, I don't think they're really long. I use these with my students. I
Mhm.
make them I
That's
make them
great. That's right.
watch
That's why they're there on Aphasia Access for sure. For
Yeah,
sure.
but they're very helpful and they do explain it very well. And we tend to use the World Health Organization model and the international classification for the framework for
Yeah.
disability,
Yeah.
and look, and that's where the life participation approach happened with the body functions and all that stuff. So I think that is the Aphasia Access website is really great to help
Oh,
for
it's
those
amazing.
of you who want more information and really want to delve into that a little bit more. And those are people who are researchers for at least as long as my career and before,
Yes. Oh, for
for
sure, for sure.
for
It
aphasia, who are very well known and textbook writers and continuing to contribute to research for all aspects of aphasia. So I think that's
yeah,
a great starting point.
yeah, for sure. Trying to think.
Becky, this was great. Thank you so much for agreeing to be on, and we could probably again talk about this for a whole other
I know we
hour
didn't talk
plus.
a ton about treatment. I was thinking, "Oh my gosh, we could have gone on for another couple of hours." But yeah, there's so many. If you Google or go on the ASHA portal for
Mhm.
looking at evidence-based treatments for PPA, that's great. You've got those. The important thing is getting those goals, like we talked about, and integrating those into the goals and getting care partner training all along. And yeah, and support groups and whatnot. We run, if you have them go to the National Aphasia Association as of now, which is 2025, we do have PPA chats there.
Yeah.
We're creating a resource bank. So, yeah, working all of us together to help this population. I'm just so grateful, Renee, for the opportunity to talk with you and share. And this has just been really wonderful. Thanks for having me.
Yeah, of course, I'd love to have you on again, and we'll talk about that after.
That sounds good. We have a lot more to cover. Yeah, this is great. All right.
Becky, again, thank you so much, and we look forward to seeing you again, working with you.
Sounds great. Thanks so much, Renee.